Thanks, everyone. Good morning. I appreciate the opportunity to participate. These are my disclosures. I think throughout the theme of this morning has been a comparison between some of the off-the-shelf branch devices and then parallel grafts. And as a prior champion, certainly, of this technique, certainly in the U.S., sort of after FDA approval, tend to agree with most of the speakers that really it's been for on-label use, and that parallel grafts still are very important in the armamentarium, and that I sort of continue to say and claim that they're complementary techniques. And I think even Mark's presentation about combining the things has some validity. And we've spent a lot of time over the last several years debating these things. But certainly, to summarize the theoretical advantages of parallel grafts, there's no wait time. It's perfect for urgent and emergent cases. It's a bailout when there's coverage, and/or shuttering. It can be used and has been shown throughout this morning in various combinations that it seems to work, and people have favorites for it. And I think the published literature would certainly suggest at this point a very flexible main body endograft plus a balloon expandable covered stent seems to work the best patency-wise. Certainly, the branch angulation, meaning whether something is caudally directed or cranially directed, makes it easier to deliver the target stents. And then one of the big advantages, I think, is as soon as you get in to one of the renals, then the main body graft, which was really the purpose of the talk, is that it doesn't matter the rotation, and so the issues with iliac access and tortuosity probably become less important. This is kind of how we do it. This is from Gustavo's book. We have two teams, left arm is out. What I wanted to show is, depending on if you have 1, 2, or 3, this is kind of how we do it. 2 is probably the favored approach, a high axillary cut or a high brachial cut down for 2 sheaths. When we have to do more, then we'll sew in a conduit to the infraclavicular, and then the arm is down. So the standard way that we've done it, sheaths down into both downgoing renals. Placement of the main body graft doesn't matter how you really align it, except to get the fabric as close to the superior mesenteric artery as possible. The inflation sequence we've seen all morning, and the balloon molding. So certainly, when you start doing fenestrated, that has to line up much better. There's obviously multiple techniques, fusion-wise, pre-loaded wires, and markers on the branches to help you align that. Combining strategies, we've seen that already for ones that have significantly downgoing large aneurysms. The strategy here was for the downgoing one to place a chimney in, and then a fenestrated graft for the other branches. This allows us to basically get four branches treated, SMA and the upward going renal, and then a scallop or a large fen for the celiac. This is at several year follow-up, 4-year follow-up, significant sac shrinkage, and still patent. So since alignment is not as much of a concern from a procedural standpoint during parallel grafting, maybe it affects the gutter endoleaks and therefore could be important. So we wanted to answer this question. This was published last year, presented at the SCVS. We wanted to look at the orientation of renal chimney grafts and see whether this was associated with gutter leaks and/or patency. So chimney graft orientation, it can come as a sweep generally because there's really no purposeful delivery of it, meaning you just get into the target branch and however it lays, it lays. So we decided to measure things at the level of the superior mesenteric artery, halfway between the SMA and the renal target, and then right at the renal target. And so we defined this for 109 snorkel grafts that half went into the right renal, half went into the left renal, and a handful went into the SMA. They were mostly balloon expandable ICAS, a couple of Viabons, and some particularly tortuous ones. So when you look at this is for the left renals. We charted the clock position in a circle where they went. This is between the SMA and renals, and this is at the target branch. We did the same thing for the right renal grafts. This is the sweep of all of them. And so what we measured was the arc that it went in terms of number of degrees. And so obviously the ones that sweep over 90 degrees circumferential, we postulated perhaps that could be a problem. Turned out that only 15% swept over 90 degrees. And again, this is an example of a chimney graft that comes straight down, one that comes over 90 degrees circumferentially, and one that wraps around 180 degrees. And you might imagine the gutters are more promoted when you have to wrap around a further distance. And so, in fact, if you look at the paper, then the predictors of the ones that had greater than 90 degree polar trajectory is the number of chimney stents having a significant downward angle protects you from it, and then the main body diameter protected you from it. Patency in this series, out to 3 years was excellent, of about 90%, and greater than 90 degree sweep of a downward going chimney predicted that there was a persistent gutter leak. So we think, in summary then, the chimney grafts that traverse 90 degree polar orientation within the seal zone are the ones at highest risk for gutter endo leaks, and perhaps using directional sheaths to force the chimneys into a straighter lie is probably the way to go, and that the ones that are the most straightward, downward going, and perhaps posterior rather than anterior on it favors that trajectory. Thanks.